So now we're going to move on to the third principle of pharmacokinetics, distribution. And we'll return to this same slide again as a good anchoring point. So we've talked about you give a drug, you measure the amount of the drug that's absorbed by measuring the bioavailability. The drug has now reached the circulation, and the minute it starts to reach the circulation, it doesn't stay still. It gets distributed throughout the body. So distribution, which is what we're going to talk about now, refers to that process of transfer from its point of entry into the systemic circulation and distribution into tissues. If I could bring you back to that first example that we talked about, taking aspirin for a pain in your finger, of course, we want to try and reduce the elements that are causing the pain in the finger. But we also want to appreciate that aspirin is going to a multitude of sites throughout the body. And we need to have a reasonable understanding of where we can expect the drug to go in this process of distribution. So what's the definition? The process by which a drug reversibly leaves the bloodstream and enters, i.e. distributes into, the interstitium and or the cells of tissues. So essentially throughout the body. Once a drug enters the body, from whatever route of administration, it has the potential to distribute into any one of three functionally distinct compartments of body water, and or to become sequestered at a particular site. And we'll talk about this in much more detail. It is important to appreciate that drugs don't disseminate equally into all body compartments, and they distribute in very unique ways. And we will discuss this to a certain extent. So looking at drug distribution using a picture. So up here at the top, we have a schema of an injection going into a container. So we see the entry of a drug into a container that has blood in it, just for simplicity's sake. This would infer that the drug gets administered and nothing else happens. And the response would be graphed out over time on the x-axis and amount of drug in the blood on the y-axis. So it would look something like this: rapid IV administration, and then you get a sustained concentration. Well, not too surprisingly, this is not what happens in the human body. A better depiction is the drug gets administered, it ends in the systemic circulation. Imagine this is the vena cava or the aorta in the body, and then it gets disseminated throughout the body, through the circulation into the individual tissues. Now your graph is going to look a little bit different. You're going to administer the drug at time 0. It's going to reach this high concentration, particularly if it's given intravenously, and then it's going to disseminate. And you're going to see this curve appear where you get a peak level in concentration that diminishes over time. Now, I will caution you here to say this is somewhat artificial, because the picture is much more complicated than this. Not too surprisingly, distribution occurs also within the context of elimination. So the minute the drug hits circulation, some degree of elimination is occurring. So in reality, this graph is artifactual, but it depicts the concept of drug distribution for teaching purposes. So we said that a drug could distribute into 3 functional compartments. So let's take a look at those. The first and the smallest is plasma. And in an average man, there is approximately 4 liters of plasma. In addition to plasma, then is the fluid that is considered extracellular or extracellular fluid. And this volume is approximately 14 liters. This includes plasma, but also interstitial fluid, the fluid that exists in between cells. Total body water is the combined volume of plasma, 4 liters, interstitial fluid, and intracellular fluid volume. And the total body water is estimated to be somewhere around 42 liters. And then we have the opportunity for some drugs to be sequestered in different tissues. For example, you can chelate certain drugs in bone. Adipose tissue becomes a common uptake site for some drugs. In pregnant women, the fetus, if the drug has the ability to cross through the placenta into the fetal circulation, the fetus becomes an additional site for distribution of medication that might be taken during pregnancy. So these 3 compartments, plasma, extracellular fluid volume, which is the combination of plasma and interstitial fluid, total body water, which would be plasma, interstitial fluid, and intracellular volume, are 3 potential compartments into which a drug might distribute. And then additionally, it might sequester in individual tissues. So what determines this process? Well, much like we had multiple determinants for absorption, we also have multiple determinants for distribution. Many are the same. For example, blood flow. If you have good blood flow to all sites throughout the body, well then there's a good chance that the drug will distribute to those same sites. A second point, very important, is capillary permeability. And here we're going to emphasize the difference between capillary permeability, for example, in the liver versus the brain. And the brain has what is referred to as the blood-brain barrier. This is an extra layer of protection between the brain and the rest of the body that has, from an evolutionary perspective, evolved to try and protect the brain from any toxins that may exist anywhere else in the body. The downside is that it also can protect, or more appropriately, prevent drugs from getting access to the brain that we might actually want to get access to the brain. So capillary permeability, particularly when we're comparing the brain versus the rest of the body, is an important concept. Then the solubility of the drug itself. Is the drug hydrophobic? Doesn't like water. Hydrophilic? Does like water. Lipophilic? Likes fat and therefore transits more easily. And we'll return to the permeation principles that we discussed previously when we talk about these. And then finally is the concept of binding to plasma proteins. And we'll discuss that in some more detail. So let's first of all talk about capillary permeability. You have 3 panels on this slide. Let's first of all start with panel A. So in panel A, we are showing you the structure of an endothelial cell in the liver. The real appeal of the endothelial cell in the liver is that it has large fenestrations, which I think we can see here. Fenestrations along this capillary membrane allows transport of water-soluble molecules, hydrophilic molecules, small molecules, allows movement of these molecules, including drugs, across that membrane. In addition to that, there are this concept of slit junctions, which are shown right here. These also allow the transport of drugs, molecules, across the basement membrane into the intracellular fluid, which is where many of these drugs have their primary effect. In contrast, in panel B, we are showing you the structure of a brain capillary. Here, the basement membrane is contiguous. The tight junctions are so tight, it allows very limited transport across the basement membrane. This we refer to as the blood-brain barrier. So the permeability that we're trying to emphasize, or the concept we're trying to emphasize, is shown in panel C, where there is very limited ability, certainly for aqueous or water-soluble molecules, to cross through that impermeable blood-brain barrier, or that impermeable basement membrane, with the absence of these fenestration or slit junctions along the cell membrane or the basement membrane. In this situation, you are totally dependent on specific carrier mechanisms, or sometimes on lipid solubility of drugs that have the ability to transport across the cell membrane, but also would need to have the ability to cross the basement membrane. To revisit ever so briefly the permeation principles that we talked about before: aqueous diffusion, water-soluble molecules moving from high concentration to low concentration until an equilibrium is achieved; lipid diffusion, following the Henderson-Hasselbalch principles, where a lipid molecule will diffuse through the lipid bilayer of the cell membrane; special carrier mechanisms which are saturable; and then the concept of endocytosis on the luminal side of a cell membrane to exocytosis on the contralateral side of the cell membrane. Let's move on now and talk a little bit about plasma proteins. Plasma proteins include albumin and a whole range of globulins. They have many functions, but one of their functions is to carry drugs and other molecules around the body. Typically, when drugs are attached to plasma proteins, they are considered sequestered. And when drugs are sequestered or attached or bound to plasma proteins, they exist in a non-diffusible form. Where are plasma proteins? Well, they're in plasma, not too surprisingly. And what they do is they keep the drug within the plasma compartment. Now remember, we said previously that the plasma compartment on average is about 4 liters. So if a drug is highly bound to plasma proteins, well then its distribution is going to be limited to that plasma compartment. So what's the role of plasma proteins? So when the drug is bound to the plasma protein, it's inactive, so it limits its potential to have a pharmacodynamic effect. It is important, however, to appreciate that binding to plasma proteins is typically reversible. Also, plasma proteins have varying binding capacity. Now remember, we use this word capacity when talking about specific carrier mechanisms. Capacity is the inherent ability of the molecule, the plasma protein in this example, of actually binding the drug. So it could be something as simple as one drug molecule for every plasma protein, or several drug molecules for each plasma protein. Plasma proteins also have different affinities. Now we've mentioned the word affinity once before. Affinity is the natural attraction that the protein will actually have for the drug. So what's the draw of the protein on the drug? And the affinity will determine how strong the binding will be to the plasma protein. For example, albumin binds weak acids and hydrophobic drugs with pretty strong affinity. Competition for binding sites may also occur. So drugs might compete for the same binding sites. And it is the drug that has the higher affinity that is going to displace lower affinity drugs. So let's, for example, say we are administering drug A and drug B. Plasma protein Y has a high affinity for drug A and a lower affinity for drug B. Let's say you give drug B first. It binds to the plasma proteins. Along comes drug A. Because it has higher affinity for the binding sites, it's going to displace drug B, and drug A will preferentially be bound by that plasma protein. The impact of binding to plasma proteins on the overall effect of drugs, the pharmacodynamic effect of drugs, is unclear. So we appreciate the principle of plasma protein binding, but we don't truly understand what the clinical implication on the effect of the drug might be as a result of plasma protein binding, displacement, competition, affinity, or capacity. So what we say is we need to know the principle. The application of the principle is a little bit of a quagmire. How does plasma protein binding alter the pharmacokinetic principle of distribution? So let's, for example, go back to drug A, drug B that I talked about previously. If drug B is displaced from its binding site by drug A, and the volume of distribution is small, then the concentration in plasma will be higher, with the potential, of course, of increased toxicity. If the volume of distribution is large, then the displaced drug can distribute into other compartments without any real concern of toxicity. It's important to understand the interplay between plasma protein binding and how volume of distribution might be altered. Clinically, drug displacement from plasma proteins is considered to be a common cause of drug-drug interaction that may or may not have clinical sequelae. So we're going to talk a little bit of math here, but not too much. How is distribution measured? Well, we use the term volume of distribution, or VD for short. The definition of volume of distribution is a hypothetical volume of fluid into which a drug is disseminated prior to elimination. Why do we use the word hypothetical? Well, the reason is the following. As soon as a drug hits circulation, hits the systemic circulation, elimination begins. So this part of the sentence, prior to elimination, is actually difficult to measure and difficult to imagine because distribution and elimination are occurring concurrently. So for accuracy's sake, we say a hypothetical volume of fluid into which a drug is disseminated prior to metabolism. So how do we calculate it? Well, the volume of distribution is the bioavailable dose, remember what we talked about previously, divided by the concentration in plasma at time zero. So just think about that IV administration. You inject the drug, let's say as a bolus, it's that concentration in plasma at time zero. Bioavailable dose divided by the concentration in plasma at time zero. It's typically expressed as liters, normalized for body weight. This makes it a transferable value. So this is represented as liters per kilogram. And we, even though we don't use a metric system in this country for bioavailability and drug distribution purposes, we do. So liters per kilogram. If a drug is distributed throughout total body water, the volume of distribution would then be 42 liters. Remember we said total body water was 42 liters, those three functional compartments added together, divided by what is thought to be a typical male body weight, 70 kilograms. I think we might be a little bit off in our estimate there. So 42 liters divided by 70 kilograms, more easily represented as 0.6 liters per kilogram. So any drug that is shown to have a volume of distribution of 0.6 liters per kilogram would be considered to have a very large volume of distribution. In other words, it is disseminating throughout all body water or total body water. It is disseminating into all 42 liters of body water that exists in a healthy individual. If the volume of distribution is calculated to be higher than this, then you can infer that it is being sequestered in tissues such as bone or possibly even fat. If it is a volume of distribution less than this, then you can infer that it is being limited through some of its determinants of distribution that we talked about previously that is preventing it from gaining access to all total body compartments. So the volume of distribution, simplistically, gives one the sense of where the drug goes in the body. Remember again, it is not talking about the effect of the drug, it is purely talking about the pharmacokinetics, where the drug goes. A large volume of distribution implies that the drug is distributed throughout the body. A small volume of distribution implies that the drug could be contained just within plasma. The type of information does help you in the drug development steps that we talked about at the very beginning to allow determination of the dose that might be required to achieve a therapeutic effect. So we take this pharmacokinetic principle of distribution using the calculation VD, or volume of distribution, and we use that when we go into assessing pharmacodynamic effects of drugs and make a comparison. What volume of distribution achieved what sort of therapeutic response or pharmacodynamic response? So we will talk a lot in the future about this interplay between pharmacokinetic principles and pharmacodynamic observations. So let's tie distribution together once and for all. Plasma compartment is 4 liters. If a drug is contained within the plasma compartment, using what we know about the determinants of distribution, we could imagine that the drug would have a large molecular weight, or that the drug is heavily bound to plasma proteins, thereby containing it within the plasma compartment. That the drug is too big to pass into the interstitial fluid, or is bound and therefore not free to do so. Let's say another example, that the drug has disseminated into the ECF, i.e. the plasma plus the interstitial fluid. And remember that total volume is somewhere in the ballpark of 14 liters in a healthy individual. Here one could imagine that the molecule has low molecular weight and it's hydrophilic. Remember those permeation principles. The drug is moving easily through those aqueous channels. It can move through endothelial slit junctions into the interstitial fluids. These drugs therefore distribute into the larger volume of plasma plus interstitial fluid. Let's say the drug disseminates completely into total body water and has that volume of distribution of 0.6 liters per kilogram. So here you could imagine a multitude of scenarios in reality. The drug could have a low molecular weight, could also be lipophilic, and therefore it's moving through the cell membrane using that permeation principle and the Henderson-Hasselbalch equation, so that the drug is moving easily across the lipid bilayer. Therefore, these drugs could distribute everywhere. They could get into plasma, interstitial fluid, or into the intracellular fluid volume as well, a total of 42 liters. And then you can imagine that a drug is sequestered into tissue such as bone, as we mentioned previously, or it could be bound to receptors at its targeted site of action or to a carrier mechanism. So this gives you an example of some physical volumes of some body compartments into which drugs may be distributed. Here on the left-hand side is the compartment and the volume, and we show water, fat, and bone as 3 different types of tissue. Underwater, we have total body water, we have extracellular water, and then we have plasma, as the examples shown previously. And on the right-hand side are just some examples of substances that you're all probably pretty familiar. Ethanol is alcohol. Gentamicin is an antibiotic. Heparin, we talked about before, is a drug used to prevent blood clots. DDT is an insecticide that is used in a lot of weed killers. And then ions such as lead, fluorine, that can be sequestered quite easily within bone. And in parenthesis, beside all of these, you can see the examples of types of volumes of distribution that might be achieved if a drug is sequestered into different sites. So again, let's take a breather and see how we're doing. So take a moment to consider, what are the determinants of drug distribution that we've talked about so far? And the answer to that question is blood supply, the permeation principles, aqueous, lipid, specific carrier mechanisms, endocytosis, exocytosis, and then the third element, plasma protein binding. So we're going to complete this section, and here are the objectives that we have achieved so far. We've described the different routes of administration. We've defined absorption, And we've identified the relationship between administration, absorption, and bioavailability. And most recently, we have described the determinants of distribution.